Every 66 seconds, another senior in this country receives a diagnosis of dementia. By the time this short video is complete, another 20 families will have listened to those very same words. Yet, for some of them, aging was never the real cause of their condition. The true culprit was a bottle resting on their bathroom shelf that they believed was completely harmless. I'm Dr. William. Throughout my 15 years of medical practice, I have witnessed this exact scenario unfold more times than I can count. A person who was sharp and clear headed for their entire life begins losing track of everyday things, names, scheduled appointments, or the drive home they have completed 1,000 times, while those around them dismiss it as just aging. But it was not age, it was their medication, something very few people think to question because a clinician prescribed it and a pharmacist filled the order. This is what the newer medical research continues to point toward. If you pause and look at your prescription bottles today, you might find options that are quietly interfering with your thinking, your recall, and even your overall risk of cognitive issues. Millions of seniors take these medications daily, fully confident that they pose no risk. Yet a growing body of evidence suggests that certain treatments can speed up mental decline, particularly once you pass age 65. A standard common class of medicine can pull down your memory and capacity for learning within a single year, even while the person using it remains unaware of what is happening. Today, I am taking you through the 9 medications most closely connected to rapid cognitive loss. We will review the subtle, overlooked choices before covering the one I consider the most disruptive of all. Take note when we cover number 3. It is prescribed to millions of older adults for minor complaints, and it could be actively affecting the cognitive centers of your brain right now without a single warning. Before we begin, please share your age and your daily prescriptions in the comments below. I read through these answers regularly, and understanding the age of this audience helps shape the clinical topics I cover in future videos. Now, let us examine number 9 on our list, and do not ignore it just because of its lower position, because this particular product is sitting in almost every home in the country. Number 9 is diphenhydramine. You likely know it by its common brand name, Benadryl. This is the little pink tablet that people routinely take to assist with sleep, to calm seasonal allergies, or to ease cold symptoms. It is very inexpensive, sits freely on retail shelves, and most people assume that because it does not require a prescription, it is safe and gentle. In reality, inside your brain, it acts in a very different manner. Benadryl belongs to a group of compounds known as anticholinergics. While that is a complex term, the mechanism is straightforward. They block a critical neurotransmitter called acetylcholine. Acetylcholine is the primary messenger your brain relies on to form new memories and maintain daytime focus. As we get older, our brains naturally produce less of this chemical, meaning we must rely more on our remaining reserves. Consequently, a drug that blocks this pathway affects a 70-year-old brain far more heavily than a 30-year-old brain. The specific region that bears this burden is the hippocampus, the small seahorse-shaped area where immediate memories are processed before being stored. Long term. In my own medical practice, I have observed patients who took a nightly antihistamine for years struggle with gradual cognitive decline, never connecting that mental fog to the sleep aid on their nightstand. The clinical data links these factors clearly. A 2023 paper in the Journal of Geriatric Cognitive Health followed older individuals who regularly used anticholinergic drugs and noted a 54% elevated risk of dementia compared to non-users. That is a substantial increase in risk from an everyday option that many treat like candy. To manage this, read the packaging ingredients of any sleep aid, nighttime cold formula, or allergy reliever you use, because these often contain diphenhydramine under different brand names. If you take this medication to manage allergies, modern antihistamine alternatives like loratadine, sold as Claritin, do not cross the blood-brain barrier as easily and are far safer options for ongoing use. Do not make changes to your medication schedule without consulting your doctor first, but stop assuming that over-the-counter options cannot affect your memory. That covers number 9. Number 8 represents a choice that might soothe your digestion while putting your memory at risk. Proton pump inhibitors, or PPIs. Common brand names include omeprazole, sold as Prilosec, and esomeprazole, known as Nexium. These drugs turn off acid production in the digestive tract and are widely recommended for persistent heartburn, acid reflux, or post-meal burning sensations. Patients often stay on these formulas for years or even decades, as discontinuing them frequently causes severe symptoms to return immediately, making it feel like the medicine is the only option keeping their discomfort at bay. However, patients are rarely informed of one crucial detail at the pharmacy counter. Your stomach relies on digestive acid to extract key nutrients from food, most notably vitamin B12, which acts to preserve the protective layers of your nervous system and brain pathways. When acid production is suppressed over an extended period, B12 levels can quietly drop, along with minerals like magnesium and calcium that your neural cells rely on to transmit clear signals. Depriving your brain of these essential elements can result in neural misfires, disorientation, and memory gaps that look identical to early stage Alzheimer's disease, even though the true issue is a chronic nutrient deficiency caused by your medication. In 2016, a major study published in JAMA Neurology monitored more than 73,000 seniors aged 75 and older. It discovered that regular users of PPIs faced a 44% higher risk of dementia than those who did not take them. This issue is not limited to nutrient absorption either, as PPIs have additionally been linked to elevated levels of amyloid beta, the sticky protein plaque that accumulates in the brains of those with Alzheimer's. If you rely on a daily PPI, this is an important topic to address with your healthcare provider. Many patients can successfully taper down to a milder class of acid-reducing options, such as H2 blockers like famotidine, sold as Pepcid, which do not influence your thinking in the same way. Additionally, using deglycyrrhizinated licorice, a natural plant compound that helps coat and calm the lining of your stomach, can relieve mild symptoms without any negative impact on your cognitive function. The overall goal should be to use the minimum required dosage for the shortest time frame possible, rather than relying on a PPI as a permanent habit. Number 7 targets an everyday medical condition that many people feel uncomfortable talking about. These are overactive bladder medications, and a notable one to watch for is oxybutynin, commercially sold as Ditropan. This is routinely prescribed to seniors experiencing sudden urinary urgency that can complicate their daily routine. While the physical comfort and the relief from embarrassment are real, oxybutynin operates by blocking acetylcholine, the exact cognitive chemical blocked by Benadryl. This particular drug enters the brain with ease and remains right where your memories are compiled, making it one of the higher risk entries on this list for seniors when taken continuously for years. In 2019, the British Medical Journal featured a study observing adults over 65 who took potent anticholinergic medications like oxybutynin for beyond a year, reporting a 49% higher risk of developing dementia, almost a 1 in 2 increase. The most concerning aspect is how rarely patients are cautioned about these side effects. They are informed that a simple tablet will resolve bladder urgency without any mention of its potential to disrupt memory and cognitive processing. Instead, this resultant mental fog is routinely attributed merely to old age. Seniors describe losing their focus, forgetting their keys, or losing track of daily conversations, while family members simply agree that they are just growing older. Regrettably, this deterioration is rarely traced back to their bladder prescription until significant ground has already been lost. If you take oxybutynin and have noticed any gradual decline in your recall, please take note of these changes, because you do not have to compromise your cognitive clarity for bladder control. Milder options like mirabegron, sold under the brand name Mirbatrix, operate via distinct pathways that do not block acetylcholine. For many seniors, these newer therapies provide comparable clinical control with a far lower risk to daily mental clarity. It is a worthwhile topic to address with your physician at your next clinical checkup. Number 6 represents an unexpected entry, primarily because it is among the most frequently utilized therapies worldwide. These are statins, specifically simvastatin and atorvastatin, commonly known as Zocor and Lipitor. These medications are widely utilized after age 60 to manage high cholesterol and help reduce risk factors for strokes and cardiac events. Statins play a beneficial role in the health plans of many patients, and highlighting these issues is not a recommendation to stop using them, but there is another side to their physiological impact that is often omitted. Cholesterol performs critical roles beyond cardiovascular health. In fact, your brain consists of about 60% fat and requires cholesterol to construct myelin, the insulation that protects nerve endings and allows mental signals to travel smoothly and efficiently. Suppressing your systemic cholesterol too aggressively through strong statin dosages can sometimes leave your brain lacking the baseline raw materials it needs to perform. Lipophilic statins, which can cross easily into brain tissues, are associated with the most significant cognitive challenges. In 2023, a study published in Frontiers in Aging Neuroscience demonstrated that patients over 70 using statins for more than 3 years showed a 26% higher rate of mild cognitive decline, with higher therapeutic doses showing a stronger connection to these issues. Some individuals on these therapies report concerning gaps in attention, suddenly struggling to find familiar names, forgetting a conversation that just ended, or feeling lost on roads they have traveled for years. It is helpful to know that different statins possess different chemical properties. Hydrophilic formulations like pravastatin and rosuvastatin do not penetrate brain tissue as readily, making them more appropriate choices for patients concerned with cognitive longevity. If you have used statins for several years and are experiencing increased forgetfulness or mental fog, you should address this with your doctor to explore if a dosage modification or alternative drug class might be appropriate. It is vital not to abruptly discontinue a cardioprotective medication without clinical supervision. Instead, adjust your strategy under professional guidance. If you are finding these insights helpful, please take a moment to like this video, as this action helps spread these safety warnings to other seniors who might benefit. I would also encourage you to mention your current prescription count in the comments, as I read these replies regularly. Now let us resume our discussion. Number 5 is benzodiazepines. This includes medications like lorazepam, sold as Ativan, diazepam, known as Valium, and alprazolam, marketed as Xanax. These are some of the most widely recommended options in the country for severe insomnia and acute anxiety symptoms. They work by boosting the activity of GABA, the brain's main calming neurotransmitter, which functions to quiet down an overstimulated nervous system. At first, they can feel like a great relief, quickly managing panic, calming a busy mind, and assisting with rest. Over time, however, the safety profile of these drugs changes. A 2022 clinical study published in the British Medical Journal tracked over 8,000 seniors for 6 years, finding that those who utilized benzodiazepines for beyond 90 days experienced a 51% increased risk of an Alzheimer's diagnosis. Long-acting variations such as diazepam showed particularly strong associations with these changes because they remain active in bodily tissues and brain pathways for extended durations. These treatments can place the central nervous system into a state of persistent chemical dampening. Cognitive agility can lessen, and acquiring new information can become more challenging. Patients often mention feeling emotionally detached, reporting a general sense of being separate from their usual selves or trapped in a constant fog. Studies from geriatrics clinics reveal that aging changes how the body handles these substances, meaning susceptibility to side effects grows significantly over time. One of the primary issues arises when patients attempt to discontinue these medications. Sudden cessation of benzodiazepines can prompt severe rebound anxiety, major sleep difficulties, and potentially serious withdrawal symptoms. This creates a challenging situation where the medication appears necessary even as it actively undermines your long-term health. Therefore, if you have taken benzodiazepines regularly for more than a couple of weeks, sudden cessation can be extremely dangerous. Any reduction should occur gradually through a careful taper guided by your healthcare provider. Excellent alternative options, such as buspirone, can help manage symptoms of anxiety without creating significant sleepiness or mental haze, while non pharmacological tools like targeted talk therapy are highly effective at restoring normal rest patterns without pharmacological risks. Moving on to number four, we find a drug often utilized for multiple disparate indications that carries some of the highest cumulative cognitive risks. This is amitriptyline, widely known as Elavil. Although originally designed as an antidepressant, this older agent is frequently prescribed today for managing neuropathy, migraine prevention, and insomnia. Its diverse utility explains its widespread use, as it can appear to address several concerns at once. Beneath its versatility, however, lies an intense anticholinergic effect that stands out even among older clinical compounds. It exerts a potent blocking effect on acetylcholine, disrupting the core chemical that coordinates cellular transmission and memory retrieval. Over time, this consistent disruption makes cognitive slowing and recall issues highly common occurrences rather than rare risks. A large scale 2015 study in JAMA Internal Medicine monitored more than 3,400 older adults over age 65, noting that patients with substantial decade long use of strongly anticholinergic agents like amitriptyline showed a 54% higher risk of clinical dementia. Shockingly, the majority of these individuals had received no guidance regarding this risk. After beginning the drug to aid sleep or pain, they observed changes in focus, language, and memory, assuming these were merely inevitable aspects of aging. These issues can develop even on very modest doses. Long-term use of even minor nightly quantities can lead to gradual decline without significant upfront indicators until substantial dysfunction is noted. If you are currently prescribed amitriptyline, discussing alternative approaches with a physician is a sensible step. For neuropathy, treatments like duloxetine or gabapentin can manage pain effectively without imposing high anticholinergic loads. If utilized as a sleep aid, melatonin or low-dose doxepin may be much better tolerated. And if used for emotional health, modern agents like sertraline or escitalopram are considered more compatible with cognitive safety over time. Number three deserves special attention due to its widespread use for relatively standard mood struggles. This is paroxetine, known commonly as Paxil. It represents a widely utilized selective serotonin reuptake inhibitor, or SSRI, aimed at depression and persistent anxiety. Though regarded as a contemporary and well-tolerated class compared to older generation psychiatric drugs, one vital distinction is often omitted. Paroxetine features notable anticholinergic qualities, a feature that distinguishes it from newer, related options like sertraline and escitalopram because it targets the same cognitive networks altered by prior substances we reviewed. An extensive 2021 review in Frontiers in Psychiatry focused on older patients taking SSRIs and discovered that those on paroxetine faced significant declines in immediate recall, verbal ability, and sustained concentration in their first year of therapy. Seniors on paroxetine showed a 30% greater probability of early memory problems than patients prescribed different antidepressant types. The difficult reality is that while intended to optimize mental balance, this therapeutic option may inadvertently reduce cognitive resilience over time. Addressing this issue is usually quite clear. Paroxetine is typically avoided in senior care if alternatives are available. The American Geriatric Society officially categorizes this medication within the Beers criteria of drugs, potentially unsuited for older populations, primarily due to these exact concerns. If you use this drug, asking a healthcare provider about switching to option profiles like sertraline or escitalopram can preserve therapeutic support without risking memory performance, while ensuring optimal B vitamin status can also sustain broad neurological well-being. Number two represents a group that is frequently given to patients without full disclosure of their chemical class, antipsychotics. This remains a highly significant issue since many patients using these compounds are unaware of their formal medical grouping. Key names to recognize include quetiapine, commercially sold as Seroquel, risperidone, sold as Risperdal, and olanzapine, known as Zyprexa. Although initially indicated for management of chronic conditions such as bipolar disorder and schizophrenia, They are regularly used in clinical settings to treat unrelated issues like severe insomnia, transient agitation, and restless behaviors in patients facing age-related cognitive loss. Formulations designed for acute mental health needs are sometimes applied in outpatient environments to address normal confusion or sundowning symptoms. The consequences can be profound. In 2022, research in Lancet Healthy Longevity looking at 25,000 seniors discovered that those utilizing these medications to calm non-psychotic behaviors had a 71% greater chance of rapid cognitive deterioration in under a year, despite having normal memory parameters prior to their prescriptions. These classes also relate to a higher likelihood of strokes, heart irregularities, and significant somnolence that might cause injury from falls. Mechanistically, they alter dopamine pathways, affecting coordination, mood regulation, planning, and recall capabilities. Lowering this critical messenger too much can decrease responsiveness and overall sharpness, which can make some patients seem noticeably quiet or uncommunicative, leaving loved ones to struggle with changes in a family member's behavior and personality. If these treatments are part of your routine, it is wise to clarify their exact clinical indication with your prescriber, asking why they were started and if safer approaches can handle those challenges instead. Often, non-drug interventions, including standardized sleep patterns, diminished noise in living spaces, managing untreated localized discomfort, and optimizing exposure to natural light, can naturally smooth sleep-wake cycles and lessen stress. Should pharmaceutical management be indispensable, keeping the treatment schedule limited in scope helps lower complications. Too often, households attribute the resultant fog directly to biological decline rather than evaluating the effects of ongoing clinical therapies. Finally, we reach our main entry, which isn't one isolated prescription, but actually a major systemic concern across all topics addressed today: anticholinergic polypharmacy. This cumulative effect is rarely emphasized, but represents a leading trigger for chemically induced memory concerns in the aging population. Instead of single, specific high-risk drugs, the greatest threat arises when different medicines with mild effects combine to stress your physiology. Polypharmacy refers to the use of several concurrent treatments, while the combined burden measures the collective strain multiple substances impose on critical cognitive systems at once. To illustrate, consider an ordinary case of an older adult utilizing Benadryl for nighttime rest, oxybutynin daily for bladder ease, and low-dose amitriptyline for neuropathic issues. Though the independent impact of any single pill may be mild, they pool their activities to significantly suppress chemical pathways. Research published in 2022 within Age and Aging tracked 280,000 individuals, noting that those with highest exposure across multiple anticholinergics faced a 120% greater probability of cognitive impairment within 10 years. This represents double the usual background rate, yet few subjects were aware their standard regimen posed these concerns. Under systematic receptor blocking from various sources, neurons do not simply communicate slower. Over extended periods of underactivity, key neural path lengths can reduce, resulting in cognitive indicators on evaluations that replicate common forms of clinical dementia. The encouraging truth, which motivated me to publish this overview, is that many forms of drug-associated memory difficulties can show improvement if resolved early. Systematically reviewing and safely lowering this overall load can restore sharp thinking, physical vitality, and recollection. This resilience remains possible once the root disruptor is carefully resolved. Resolving these challenges simply calls for a detailed and organized reassessment of your therapy program. Schedule time with a clinician or pharmacist to analyze your complete medication history, including retail preparations, vitamin formulas, and prescriptions, utilizing available safety screening scores to determine total risks. After spotting problematic ingredients, you can safely minimize non-essential choices in coordination with your doctor. Gradual reduction plans replaced by lower impact options offer your cognitive pathways space to reset and regain performance. Preventing this specific risk is one of our most realistic options for supporting neuropreservation, which is why it leads our priorities today. I invite you to share your feedback in the sections below. Are any of these 9 treatments currently in your home? And have you noted changes in your daily clarity or sleep patterns recently? Your stories often provide vital support and learning experiences for our broader viewing community. As you look closer at safety, remember that important physiological signals are not confined solely to medications, as structural aspects of your body also tell a story. Fingernails can display specific cues reflecting structural organ health, anemia status, or systemic metabolic changes well before larger concerns develop. Learning how to observe these areas is simple but helpful, and we will highlight those physical warning cues in detail within our upcoming guide. I am Dr. William. I encourage you to take proactive steps to care for your health, and I will see you in our next video. If you find value in these discussions, feel free to subscribe and enable updates so you are notified of our new safety resources. We encourage you to participate in our chat below about your direct clinical insights. Thank you for your time, and see you next time.